A very good evening, ladies and gentlemen. We're a little bit before 7, but we're going to get ourselves underway. Thank you very much for coming out on what is a freezing cold evening. We really appreciate it. At this point, I'd like to introduce our chairperson for the evening, Jackie Robinson. She's from the Independent Consultation Institute, and she'll be handling things this evening. So I'll just pass you over.
Thank you, hello, everybody. Thanks for my introduction. I can let you know, first of all, I am completely independent. I don't live in Cumbria, as you probably tell from my Liverpool accent as we go through the evening. We do have a signer here this evening, and I just need to check if we need to retain the signer or not. Does anybody need a signer in the room? Okay, so we're going to stand you down for a little while, and we may need it later on. Okay. Big wave. Okay, and just think, just so we get some ground rules in place, really. I have worked in the NHS and social care for over 30 odd years, so I do run a lot of consultations, and I think you've come tonight because you're clearly really passionate, but I'm really clear about my brief. My job's to enable colleagues to give you the information about plan changes. There's a statutory and legal duty to do that, so we're doing the right thing, but it's your opportunity to ask questions. There's an awful lot of people in this room, and we do want to finish at 7 o'clock, and I will go through each questioner as you raise your hand. But I would ask if we could please be a little bit polite, not shout over each other, because it does get a little bit difficult to manage. Just before we start, just some housekeeping. If you need to use the loos, folks, they're straight out of this door at the back, down the corridor and turn right. If there's a fire alarm that goes off tonight, it's for real. So please go through the exits and convene in the car park at the back. If you are using a hearing aid, there's a loop system. So could you turn your hearing aid to the T-coil position and you'll have a better evening listening to us all. I'm going to introduce the panel who've come along this evening. And we'll start. Oh, there's I was looking at the end. There you are. I'd like to introduce you first to Stephen Eames, who's the Chief Executive. He's going to be doing a presentation from Cumberland Infirmary, Carlisle. Alongside Stephen, then is where are you? Oh, yeah. Oh. I think Dr. Harpen. I've rubbed you out by mistake there. Who's the medical director? Oh, that's a good start, isn't it? Then we've got Joanna Forster-Adams, Director of Operations from CPFT. Then we've got Dr. Niall McGreevy in the audience. Yeah, he's moved, sorry. Yeah. We also have Matt House, who's a paramedic from NWAS, and Claire Parker, who's a nursing director, who's joined us this evening. So we're going to start with the presentation, and then we're going to hand over to you, because this is your evening, so let's see how we go along.
Okay, now am I switched on? Thank you. Can you all hear me at the back? Can I just check that first? Can I also thank you all for coming out, because this is what these sessions are all about, to get as many views as we possibly can. I'm going to give a very brief overview. I'm not going to go on longer than 15 minutes. I'll better that if I can, because I guess many of you might have some sense already of what's in the consultation document, and we want to spend most of the time this evening engaging with you and hearing from you about your issues and concerns and points that you want to make. But as the chair pointed out, we do have to specifically set out our proposal. So I'm going to do that fairly briefly, starting with the background to consultation. The NHS, and in this particular case, we're talking about NHS Cumbria CCG, has a legal responsibility for leading local consultation. So in effect, we're working under their brief this evening. Obviously, in this part of the world, we've been working very closely as well with the success regime, which I guess many of you will have heard of. We can explain a bit more detail about that afterwards if you wish. Clearly, the outcomes of this consultation are really important in any decision-making that may happen in due course. And I just sort of want to emphasize, because I guess it tends to come up everywhere I go talking about this, no decisions have been made. Nothing has been predetermined, nor can it in the proper legal process of a national, which in effect this is, although it's a locally orientated consultation exercise. So we are here to listen to what you have to say. And actually it's more than listening, it's taking on board your views. And I believe this event, like all the others, is being recorded, so everything everybody says will be captured. And what we're going to do at the end of this process, the consultation closes on the 19th of December, is analysing all those responses, and that will be done independently. It's unlikely there will be any formal outcomes from this process, because clearly we need to give enough time for careful consideration of those outcomes until around about the spring, the early spring of next year. I should also just point out that a public consultation under the terms set out nationally for anything really, whether it's about health or any other public service, it's not a vote on the issues or a veto over the changes. In the end, the NHS will need to take a view and make decisions based on all of that analysis and all the feedback through this consultation process. Apologies for the double act, but I really don't want to be up on the stage when I'm trying to talk to you. Very quickly, in West, North and East Cumbria, we do face some very significant challenges. Population health, this slide says, is not good. I think what that means is that in parts of our county here, we've got some very significant areas of deprivation and some very high level, high incidence, should I say, of obesity, of chest disease, of long-term conditions when compared to other parts of the country. So we've got a very big challenge, and often some of the more emotive issues tend to cloud out the fact that one of our biggest challenges is to improve people's health and the health of families. So that's a very big part of our challenge. We've got recruitment difficulties. I think they've been well publicised. The NHS has got recruitment difficulties in some areas up and down the country. They're particularly acute here in Cumbria. I run the hospitals. It might sound strange when you hear stories about the hospitals being full to the gunnels and really under pressure, and that is absolutely true, and our staff do a tremendous job. But actually, about 25 and some days 30 to 35% of our patients in hospital beds, actually that's the community hospitals as well as the acute hospitals, there are patients there that if there were alternatives, they wouldn't need to be there. It's a fact, actually, which people don't often perhaps grasp easily in that context, that actually if we were just treating the acute phase of care, we've got too many beds in West, North and East Cumbria in our hospitals, which is really what we're trying to address in the big set of issues we're trying to address in this consultation. We're overspent here in this part of the world. We, around this table, have got a collective duty to run effectively as a business the money that we have. We've got a statutory responsibility through our boards to do that, so we've got a big challenge in that area. And the Care Quality Commission have identified some specific services that they rate as inadequate, and clearly we have to move away from that. So that's a quick summary of the challenges. The next thing I think is very important, and I guess this will come up tonight, and it comes up everywhere. There's been a lot of uncertainty for some considerable time about a number of the issues that we're consulting on. And that doesn't help. It doesn't help you, the public. It doesn't help us to plan services effectively. So we think collectively that we need to tackle some of these long-standing, underlying, difficult issues. And there are no easy answers. That's why we're consulting. That's why we need to focus on how we do the best with what we've got once we've got through this consultation. And we need your help. That's why the input that we will have tonight and we've had so far and will continue to do so to the 19th of December is so important. We do have collectively what I would describe as a compelling vision which builds on the strengths. So I've talked a bit there about some of the challenges that we've got in West, North and East Cumbria. We've got some tremendous strengths. Our staff, first and foremost, who are doing a fantastic job, often in very difficult conditions and in difficult high-pressure situations. I see that every day. I'm sure my colleagues do. We've also got a lot of opportunities that we're building with the local educational institutions, and one of the things that's very close to my heart and I know quite a lot about, we're working very closely with the universities in Cumbria and in the northeast, and particularly with UCLAN, in developing new ways of developing our workforce to meet some of the particular challenges that we've got here. So what we're trying to do is to create, and this is about all of our services, a centre of excellence in West, North and East Cumbria for integrated health and social care. I mean, bear in mind that our biggest challenge, as it is in the rest of the country, is older people who live longer with more complex conditions, and that demand is exponentially growing every day. So we want to concentrate on the things we do well, working hard in rural communities, together with innovative new ways of doing things, to become an exemplar in the United Kingdom and internationally. So that's a bold and ambitious vision, but I think you have to do that if you want to make significant change. I want to make a point in building on that on the next slide, about integrated care communities. This is at the heart of the vision I've just referred to. And what this is essentially about is delivering more care in people's homes, in their GP practices, in community facilities, dare I say, in community hospitals like the much-loved community hospital here. And the whole plan is built on doing more locally, closer to patients and their families. And that's what the integrated care communities are about. And the plan is for there to be 8 of those across West, North and East Cumbria. Teams working together from health and social care to deliver what I've just been describing. And the whole point of that links to my earlier point about the use of our hospitals, is to reduce the need for people to go to hospital, and actually to make sure that when you're well, to come out of hospital very, very quickly, because we all know that once you're well, that's the last place that you or your family would want you to be. And I wanted to emphasize that as a critical and a most fundamental component, really, of this consultation and this service vision that we're promoting. So just 3 or 4 other things to emphasize before I go on to the proposals themselves in the consultation document. So integrated care communities, big changes associated with that. We have a duty to you, first and foremost, but then to our regulators and others to provide safe services. We know we've got some challenges in relation to that. We have to fix them. And as a result of that, those services will be of higher quality, and they'll be clinically sustainable, which is a bit of a jargony word, but what it basically means is that we won't be patching and mending our services from year to year. We'll have long-term, strong teams delivering integrated care between health, between hospitals, community, primary care, and social care. And as I said before, we've got a duty to be financially sustainable as well, and you'd expect us to be so, to spend the taxpayers' pound as best as we possibly can and make sure that we stay in our budgets. So just to highlight the changes that we're proposing, and all the detail is in the consultation document. So what I propose to do with these slides is simply highlight the preferred scenario. So if I look behind me, I'm assuming, there it is, yes. So if you can see it, the purple one on each of these slides is the preferred option being put forward for consultation. Doesn't mean to say that's the option we end up with in any of these cases, but it's the preferred one. And those have been arrived at by a long, nearly a year-long consideration of these issues by lots of local stakeholders, obviously the services and people who run services here, and national and regional input as well. So first up, children's services, and this is specifically about how we organise children's services in our hospitals. Our preferred option is to retain inpatient services for children at both West Cumberland Hospital and Carlisle, but there'll be a difference. The more intense and complex children's care will be at Carlisle. We would keep a low-risk unit running at West Cumberland. Not that dissimilar, in fact, to what we do today. I think the biggest difference would be that we would be looking for nurses to play a much stronger role in running that facility. Alongside that, and this is very important, putting in place assessment units. These are day assessment units staffed by experts, staffed by children's doctors and nurses and other specialists. We don't have those at the moment. All the national evidence shows if you do that, a lot more children who today get admitted to hospital won't. They'll be seen by an expert at the front door. They and their families will be supported to get back home. And we anticipate quite a reduction in demand on our admissions as a result of putting those changes in place. So that's children's services. If I go on to maternity services next, and again, the purple type shows the preferred model. It's important to point out here that all of the antenatal care stays exactly the same as it is in any future arrangements. The preferred model that's being put forward in consultation is to concentrate complex maternity care at Carlisle, and that in a consultant-led unit. In other words, a 24/7 facility with consultants round the clock, with a midwifery-led unit at West Cumberland Hospital. Now, in every meeting we've had, there are lots of issues about that. I guess there will be this evening. But that's the preferred scenario. If we move on to the next one, if I can turn my papers over. Sorry about this, folks. So, community hospitals. Again, there's quite the details in the document, but the preferred scenario is consolidation of our hospital beds on 6 hospital sites. Specifically here in Keswick, there's an expansion in the number of beds proposed from 12 to 16, as you may well know. But I really want to just make the point when we talk about this that beds are important, but what's equally important is how we organise our services with the community hospital at its heart to make sure we're doing much, much more locally than we are today. So the hospital is at the centre of that in this context. On emergency and acute care, our preferred proposal in the document is to sustain 24/7 accident and emergency services at West Cumberland and at Carlisle. And therefore things will remain much as they are now, but the ways in which we're going to deliver those services, particularly about how the workforce will be organised, will be different. And that's about meeting some of those workforce challenges. And then finally on stroke services, the recommendation here, and it does follow international and national experience around best practice and better outcomes for our patients, is to create a dedicated hyperacute stroke service at Carlisle. The most important thing if you have a stroke, once it's been identified, is to get to the place that can provide you with every input you need within 3 hours. We cannot do that in both of our hospitals effectively at the moment. That's why we're looking to concentrate our expertise so we can. Personally, I am totally convinced from my experience that will be better for patients and will save more lives. So that's a quick summary of the proposals. And then if I could just move on to a couple of final slides, and I'll hand back to our chair. I mentioned the financial position. This slide simply summarises it, so I'm not going to go through all the detail here, but essentially we're overspending to the tune of around about £70 million in total in health at the moment. If we don't do anything, that's going to grow. It's going to more than double between now and 2020, so clearly we can't do nothing. We've got to do a lot to try and contain those costs and make sure we spend our money well. Finally, and I know we're not in the locality, but I think I'd just like to make this last message about West Cumberland Hospital. But if I can just put it in this context, both of our hospitals, Carlisle and West Cumberland, are relatively small. They're 2 of the 7 smallest hospitals in England. And the realities of workforce, quality standards in particular, mean they must work together. And neither hospital, unless they work together and teams work together across the whole of our part of the county, will be able to create clinically sustainable services in the future. So I just want to make the point that these points are about West Cumberland because that's been attracting quite a lot of media attention. Can I tell you that Carlisle has got some similar challenges as well that we also have to address? So just about West Cumberland, as part of this returning services to the local community, we've already returned some trauma surgery, some general surgery. You know, if you've got an abscess on your bum, why on earth would you want to travel to Carlisle to have that dealt with when it can be dealt with very professionally, locally? Why on earth, if you've got a simple broken ankle, why should you travel 30-odd miles to get that fixed? So we're fixing that right now. But we're also going to be taking a lot more planned surgery. And what we're also planning to do, and I think it's a really important point, is at the moment, if we took 50%, which is 7,000 patient treatments attendances, of the people who live in West Cumberland who travel to Carlisle and repatriate it to West Cumberland, which is our plan, that's a massive shift. And what that means is that hospital will be doing more in the future than it is today. And that's our plan. And that doesn't always get across, dare I say. I don't know whether our media colleagues are around, but you know, if you want to pick up one of the headlines from tonight, I'd like you to pick that up because I haven't seen it yet. It's an important, positive message. We're also spending £3 million on a new diagnostic suite for breast cardiology and vascular care at West Cumberland Hospital. And at the moment, under decisions made by myself and other colleagues in the community, we're spending £10 million on the hospital right now. That's part of that scheme, as are a number of other things that I won't go into the detail of. So there is a vibrant future in these proposals for both of our hospitals. And on that note, I'm going to finish and hand back to the chair.
Okay, thank you very much. Just for those folks who've come in a bit late, if you want to come and take your seats, there's some seats up front. It's we've a while to go yet, so you might want to have a seat just before we start off. As I was explained at the very beginning, this is being recorded. It'd be really helpful if you could explain when you ask a question what your name is there a particular topic area? So we've just heard there about 4, 5, 6 services: children's, maternity, community hospital, emergency acute and stroke. So it may be easy for us to understand who you are, is it a particular area, and if you're from an organisation. Because this is being recorded, if you prefer not to leave that information, it's entirely your choice. But I just needed to tell you that. So I'm going to make a start. Okay, and I'm going to take a show of hands and we're going to work around the room. So we've got plenty of time, it's only 7:20. Should we start with the gentleman in the front?
Thank you. It's David Byrne, Keswick Town Council, and I'm Town Mayor this year. This is, although the report is, the consultation document is very wide-ranging, I suspect the majority of people here this evening are here about the future of Keswick Hospital. We've had a town meeting about it, we've had 3 public meetings about it, and all of the meetings have had one thing in common: they've been packed out. And that to me is a clear demonstration that when something that people in this town cherish is seen to be under threat, we turn out in numbers to defend it. I found it particularly heartening at one of the previous meetings we had, that when we had some of the town's GPs here, that they made the very valid point that Keswick Community Hospital takes a tremendous amount of pressure off the 2 acute hospitals in Cumbria. And reading through the consultation document, I see we've got 4 options for the community hospital section. The first 3 of which all provide for the retention of Keswick and in fact include an increase in its inpatient beds. Whilst I wouldn't wish a hospital closure on anybody, my personal difficulty is that because I haven't got a feel for the National Health Service like you guys have got, I can't tell you whether I think option 1 is better than option 2 or option 2 is better than 3, etc., etc. But I can only speak on behalf of Keswick. We want to retain our hospital, whatever it takes. And my question is, apart from turning up at meetings like this in force, showing that we actually care passionately about what goes on in our town, what else can we do to help you go for, if you've said that, the report has said that option 1 is your preferred option, I'm very happy to back you 100% on that. If you're the experts, but what I'd like to know is what more can we do to make sure that we don't end up with option 4, which is the one option that excludes Keswick Hospital.
Yes, thanks very much for that comment. So I'm Joanna Forster-Adams. I'm Director of Operations at the Partnership Trust, and in fact I've attended a number of these events in Keswick, and you're absolutely right, people do turn out in numbers and are always very passionate. So from my perspective, one of the really impactful points at which we started to think about the future of community hospitals was hearing some stories that derived from Keswick. And what they were at the engagement event were a series of personal accounts of what it was that Keswick Hospital actually offered. That wasn't just about inpatient care, but it was about being able to provide care, intervention and diagnostics and treatment, all based from the community hospital. And that was incredibly powerful. So from our perspective, we've listened to what people have said. We've reflected that in terms of our preferred option. What will be really helpful for us now is to hear, not only en masse in meetings like this, but for people to individually respond to the consultation. And I know that Mike Bullman is here from the League of Friends tonight as well, and certainly Mike has made representation too, that one of the most powerful things for Keswick would be for people to respond in their numbers. So to take the time to actually respond in writing from the consultation document would be incredibly helpful and very powerful, and certainly inform our thinking.
Rod Thorrington-Smith. To what extent, we need to stay within our budget, to what extent is the public finance initiative at the Cumbrian Infirmary screwed up the budget so that a lion's share of the budget has been swallowed up by that already, leaving the pickings to be distributed to the rest? As a minor additional point, please retain the minor injuries unit at Keswick Hospital. It is very useful.
Okay, I mean, I can take the first part of the question, and perhaps, Joanna, you want to pick up the minor injuries point, which I'm sure will be retained. The facts of the matter are that the private finance initiative is subsidised in our budgets by the government since it started. And I think I see this a lot in the press and in other ways. It has no impact on our finances in that sense. It's covered off. The biggest issues to do with our finances are that we're duplicating services, taking too many steps, could actually run services a lot more efficiently if we were integrating them in the way that I briefly described in the consultation exercise. And I draw the comparison with West Cumberland Hospital. We've just spent £100 million on that 2 years ago. That's capital expenditure. That came from central government. We have a levy to pay on that as part of something called our PDC, and it's covered by that levy every year. So I think it is wrong to say that PFI is affecting the finances. The finances are affected partly about how efficient we are. And I'd just like to make a further point, which I mean, I think comes back to perhaps was your underlying point in your question. We all believe, and certainly I've not been in the county very long, not quite a year yet, but the funding formula for Cumbria and for West, North and East Cumbria doesn't really work. It's weighted for population, and we have a relatively small population compared to many other parts of the country, but it doesn't take account of some of the rural issues and the access and distance issues that we clearly have here. So what we're doing as part of it's not really part of the consultation, but what we've been doing as part of the success regime process is really mounting an argument through the Department of Health with the Treasury to change that. Now, I can't say to you we will, but we are trying very hard to make a difference there.
I don't think you asked a specific question. I think you made a point about the minor injuries units, but just to say that in the proposals, we're not planning any significant change to any of the minor injuries units. It's important, though, that I think we recognise the value of those units, and particularly here in Keswick, you'll know as well as I that we've got some great initiatives going on from the minor injuries units, and in particular the Pathfinder initiative that means that ambulances can divert people to Keswick for treatment rather than to one of the big acute hospitals. Actually, as part of the integrated care communities, we want to strengthen that. We want to strengthen that across Cumbria. But certainly we will need to think about the estate that we have at Keswick Hospital and some of the expansion that we've got in place. We'll be doing that in conjunction with you as a community, planning all of that, should we opt for our preferred option. Some of you will know, though, that in the past year or two, we have had some fragility around staff. So sometimes we can't always get staff. And that's really challenging for us. And part of the reason that we're really driving this look towards consolidation, that's because we've got great staff, but actually we want to enhance their skills so that they can provide even more specialised skills in communities like Keswick. So that's part of the reason that we're driving that. But certainly in the proposals, we're not planning any significant changes in terms of minor injuries units. And in fact, we would want to strengthen them as part of our communities.
Going to move on to another question. Oh, just right next to you.
I'm Sylvia Rennie from Keswick. I wondered whether the panel has considered how people get to hospital. If you look at a map, Whitehaven is nearer than Carlisle. But if you're able-bodied to go on public transport, it takes you about 2.5 hours travelling just to go for one appointment to the West Coast. To get to Carlisle is a lot quicker. You've got an option of Penrith and the train and so on. My husband works for social car, helps volunteer for social car trips. And he doesn't like going to the West Coast. It's always a bit more difficult, even though the mileage may be different. So if you unload a lot of able-bodied people onto public transport when they may be going to an eye clinic or somebody's got the car in the family and they can't use it, how much consideration has been given to this?
I'll just pick that up because one of the real initiatives we're looking at in connection, I guess, with just bringing care closer to home and also, if you like, taking the pressure off our acute sites is delivering more outpatient visits and low-level diagnostics in facilities like Keswick. So we've got a number of consultants, including our eye consultants, who are considering how they will move care out to closer to home, which should reduce the number of able-bodied people, as you say, travelling to what are easily able with modern technology to be delivered locally.
Could I just add a point which comes back to your important opening remarks about the options? One of the challenges in doing that is we don't have enough doctors and never will have to do that everywhere. So I think when we're thinking about this consolidation, we have to think about, people in my world talk about hubs of care, but in other words, places where it makes sense to concentrate the sorts of activities that Rod Harpin is talking about. So if you come back to the proposal here in the preferred model, which is saying we should concentrate as much as we can in Keswick around the community hospital, but as I endeavoured to say in my presentation, not just to get fixated on the hospital, this is about the whole set of services that we could provide around the hospital in people's homes and so on. Then logically, we in the acute services would organise our eye services or whatever it might be around those consolidated sites. So it is a really important point and one hopefully you can emphasise in your response.
Yeah, I'd just like to add to that. It was about really the stories that we heard here in Keswick previously and similarly in Penrith and in other areas. I suppose traditionally we're used to, and certainly I'm used to, getting a lot of services from an acute hospital site. I would just ask you here to think tonight in terms of actually what we're suggesting here is that those things that would routinely be provided in an acute hospital site could in fact be provided in our communities, and that's one of the real aims that we're trying to achieve here. So that's a fantastic point actually, and we need to build on that. So the more that we can hear from you about your experiences and some of the services that you would prefer to be offered on a more local basis, that would really add to our thinking in terms of how we develop services moving forward.
I was particularly thinking about the breast screening service, which is at Whitehaven.
Yeah, and I mean, I don't know whether or not Stephen could comment on that specifically, but my personal experience is that that can be provided from a mobile facility, and something certainly that we would be looking to develop for the future for North, East and West Cumbria.
Either Rod or I could have answered that, but indeed so. I think there's a distinct, what I was describing was a diagnostic service for local people in West Cumbria. When I was talking about that new unit, I was talking about that, not about screening. Now, screening can be mobile, and I think that's, again, an important point for us to pick up, especially in an area like this where, as you say, access is a challenge.
Okay, can we move on to another question? There's a gentleman in the front here now. What do you say? Thank you.
I was meeting at Penrith, and one of the things that was said was it wasn't all about saving money, it was about improving patient care. Now, I haven't got the sanitised version of your thing, I've got the actual version, yeah? And it has pages in it where it says the final draft for comment, not for wider circulation. And it also has 3 appendices on finance. So if it isn't about saving money and improving patient care, why is there so much in this document about finance? And the other points that I've made quite a number of points that actually come out of there on various patient use. It says, how will reducing the number of beds cater for increased growth in patient numbers? Page 60. How do you propose to have a single front door for digital access where no internet exists? I mean, even today we've got one at the farm to put all your goats, sheep and cattle movements on the internet, online. We haven't got any online. You state, providing more care closer to home. How do you propose to more care closer to patients' homes when hospitals are isolated and closed and local care homes are centralised and the care in the community care budget has got to be reduced by £24 million over 3 years? Page 79 of your report states, community hospitals have a long history in West, North and East Cumbria and are strongly supported. Overall, they deliver a high standard of nursing care and excellent patient experience. And page 104, view their information online to their records. How do you propose to do this to provide security and data protection unless you have patients' permission to view them? Technology-enabled workforce. Well, that's the biggest joke in the plan. Technology is not work associated with the NHS. Look at the National Patient Medical Records computer debacle that's cost hundreds of millions of pounds and been knocked on the head. If patient is in hospital and needs to be taken to the X-ray department or to another department and a porter has to take them in the Cumberland Infirmary, it currently costs £56. No wonder the NHS is in dire straits.
I think we've lost a little bit of sound. There's quite a number of points there, folks, so we'll try and chunk them up and we'll make sure that the response is there. So there are a number of issues there around care closer to home, reduction in beds, technology, digital. So can we start this way?
I'll kick off and then perhaps go back that way. I mean, just on your headline point, of course it's about the money. I don't think anybody in this room would expect the people who are stewards of your local health service to do anything else but try and manage the money as efficiently as possible. I tried to point out in the presentation Frankly, if we're shipping people up and down the road for minor treatments, it's a lot more expensive than doing it in their home or in the GP community or actually in the local hospital. So, it is about cost, and the task that we have is to make sure that we use our money wisely and drive up quality. The two things sit together. All the evidence will tell you, if you have no infections in your hospital, which I'm glad to say you don't in any of your local hospitals, that saves a lot of money. Because if you've got people with serious infections, they stay in beds longer, the care they need is greater, they need more specialists. So, money has to be a big part of this. The other thing I would say to you, I think you're referring to the business case, the document. What you didn't say, which is really, really important, and I must say this, is this isn't just about persuading the Treasury that we know how to manage the money locally. It's about persuading the Treasury to give us £100 million worth of capital. 35 million of that to spend on a new cancer facility in Carlisle. Now that's a massive improvement. Modern technology enabled by technology in a very different way to we have it now. Money to be spent on community hospitals, money to be spent on finishing off the West Cumberland Hospital development. So actually it's also about inward investment, provided we can describe to our masters, so to speak, that we have a very efficient plan to manage our budgets and our resources in this part of the world. I would differ with you about technology. I mean, it's only the other day I was in a clinic where actually if you're a lady having a baby and you've got a complexity, the doctors locally can actually, through technology, share scans and other details with experts in Newcastle. So you don't have to go anywhere if you're that person in the antenatal clinic. That's a great use of technology. We're already, Rod would tell you, in our stroke services that would be enhanced by our proposals, part of a network of 9 other hospitals where we can share brain scans across. So I think technology is a massive part of the future agenda, and rightly so. And we've got a lot to do to catch up.
Yes, sir.
Can we let the panel answer your questions, and you've got other people to ask questions.
In this report, you've cut £10 million out of this final spend for the West Cumberland Hospital. That you haven't mentioned.
Can we give the panel the opportunity to answer the questions? Thank you very much.
I take your point about the availability of mobile communications and broadband, but somehow we have to get to the point, and you also made the point about the failed national medical record. But the fact is that Stephen's alluded to some of the technology gains we're making, but there are also very simple things. If we could share the record between general practice, our partners in the Partnership Trust and the Acute Trust, if we could get to that point, we could make healthcare much safer. So we have to establish this as a goal. For instance, there's no point when somebody comes to the Acute Trust relying on the little scrappy list of medications which people tend to carry with them. That's fine in certain circumstances, but we can now share those sorts of lists of medications with general practice, and we have to aim to make our care safer by that sharing. You talk about putting in place sharing agreements and making sure the data is kept confidential. Of course we do. And people can choose under a lot of circumstances not to share certain aspects of their care. But overall, simple sharing of data between the proposed ICCs, general practice, community care, and the Acute Trust must be the way we look at the future of healthcare. We mustn't rely on just little, communicating by small bits of paper. It's got to be done better than this, and it can be done better than this.
I was just going to add really around looking at providing care closer to homes, and essentially that's the essence of what our integrated care communities are about. We know that when people go into community hospitals, the longer they spend in any hospital bed, the less independent they become, and actually by making making it easier for people to move out into their own homes, their independence increases and they're more likely to improve their healthcare as a result of that.
Okay, we're going to move on to the gentleman here in the green, and then we'll come back to you, sir. We'll work our way through. Thank you very much.
Tim Hooper, Keswick GP. We're very pleased that many of the options include an expansion of inpatient beds at Keswick Hospital, and the reasons for that are more than just parochial. We do recognise a responsibility to providing healthcare elsewhere in Cumbria. It's not just about Keswick. We are ready, in fact we're straining at the leash to implement the integrated care communities. The bureaucracy to allow that has moved more slowly than we would have hoped. But we do have plenty of ideas for how we can utilise public funds more efficiently, perhaps using the nursing home sector, perhaps making better use of care agencies, perhaps better able to deliver care at home and release some of these bottlenecks that are keeping, not only in the district hospitals, but in the community hospitals, easily a third of patients longer than they should be. The option to increase the beds at Keswick, we have plans where we can use those extra 4 beds to greater effect. We already have good working relations with specialist geriatricians. I'm sure that those can be developed further to allow for day assessments. Keswick Hospital has had an excellent reputation, well deserved. We have plenty still to offer, and we would urge the decision makers to allow us the chance to do that far into the future. Thank you.
Thank you. Mike Bullman from the Friends of the Hospital. First of all, I would just like to thank everyone for turning out tonight. Thank you very much. Keswick Hospital has been a jewel in the community for a long time. We've seen very few bed closures. We've got excellent staff. Staff recruitment has been good. And I would just like to quote from an email which I received a few days ago. I'll try and miss out the important bits, well, the named bits. I cannot put into words how important the hospital was to my mother and our family in my mother's final weeks, days, and hours. Keswick Hospital enabled my mother to spend the last few weeks of her life in a tender, caring environment, as close to home as was possible. We were so grateful that Mum was transferred from the ward in Carlisle to a place where she could die with dignity and peace, and where we were supported every day in such a loving way. Keswick Hospital is of incredible value to the rural community in this area. Now, that is only one of many generous comments that we get. And for everybody's information, the Friends of the Hospital have submitted cases to the success regime, the Partnership Trust. As has been said, it is located just some 400 yards from the A66 at a communication crossover, which enables the ambulance service to take the ambulances to the hospital to be treated by the local GPs under the Pathfinder scheme. The Partnership Trust did, some 2 years ago, put a lot of money into the hospital, which has been greatly appreciated. We've now got a minor injuries unit, which is brilliant, and wanting to be used more. The services at the hospital provide at least 25 clinics, but I would say to the panel, the Friends did provide some expensive equipment for the eye department some time ago, and for some reason, it's sitting in a cupboard. You know, can it not be resurrected? Also, we've had a request from a urology consultant in Carlisle for some further equipment, costing about £7,500, which the Friends are prepared to cover. You know, the Friends are there to help the hospital, you know. So, you know, it is our jewel in the crown. The minor injuries unit treats over 8,000 patients per year, and of course are able to be seen by the local GPs or the nurse practitioners, again avoiding transfers to the A&E departments at the two acute hospitals. Since the improvements and alterations were carried out, with the cooperation and support of our local GPs, the services at the hospital have been extended to cover care in the community. It is now being managed effectively with many agencies working from the hospital base, just like an integrated care community, which the Success regime is looking for. We hope that you are aware that Keswick Hospital is the only community hospital within the Lake District National Park. We are, of course, heartened by the recommendation in the Future of Healthcare in West and North Cumbria public consultation document, option 1 for community hospitals. We hope the implementation of the increase in inpatient beds at Keswick Hospital from 12 to 16 can be implemented early in 2017. Just one final point. We want option 1, increase the beds to 16, get on with it and listen to the people.
Okay, thank you so much. That was so well stated and so clear and passionate. There's a gentleman in a grey jacket, a couple of... Thank you.
Good evening. I'm Jonathan Hill. I'm a recently, I think, retired NHS consultant, and I live in the Keswick area. I'd just like to make some local points here. One is the hyperacute stroke unit, and my recollections, particularly of the Oxford model, is that you can have patients in for maybe only 3, 4, 5 days in your hyperacute unit, and then they're going to be transferred back into the community. That community, and Keswick Hospital being one of them, will require considerable expansion of its infrastructure in terms of training, extra beds, and extra staff. I hope you factored that into your future equation. The other point I'd like to make at a strategic level, perhaps, and to the medical director, is, has the Trust considered fellowships? This was a model that I used in my previous trust, whereby we had the existing resources, and instead of paying expensive locums, post-fellowship registrars who did like to work in the area were invited back, or they could work alongside some of your team members and excellent consultant colleagues to deliver the service. They can see whether they like it for a year or so, and then hopefully they'll apply for consultant jobs in the area. That goes hand in hand with training. We need to encourage our consultant colleagues to train more, gain the reputation, and be part of rotations. I found it very difficult when we had the Manchester rotation, or the young registrars were in Manchester, similar to Newcastle. We've got to get them out there and into this hospital and to stay. And following on from that, one final point is research. Research attracts good quality candidates. Thank you.
Yeah, I thought I would start really with your first point, which was about factoring into the equation a kind of shift in resources into community services. Certainly within the work that we've done, one of the real pieces of work that we now need to complete is about how we attract these really high caliber staff that we will need in places like Keswick. Keswick is a fantastic example actually of where people want to come and live. And actually Keswick is very commutable from elsewhere in Cumbria and on the borders of Cumbria. So having that kind of expertise in Keswick certainly from a stroke perspective, is something that we have factored in and something that we are starting to calculate how best we can do that. I'll hand over to Rod now, who I think has got some additional points to make, but certainly in terms of the metrics, we've started to plan the kind of shift of resources from an acute setting into a community setting.
So I suppose you set the challenge for the medical director to look at every possible option of recruiting staff, and there are, I mean, that was one of the points, and fellowship certainly is part of that approach. We are trying a number of what we call innovative ways of recruiting consultant staff, and in any rural model, that starts right at the point of really leaving medical school, indeed having medical school placements with both Carlisle and also Whitehaven from various sources is very key to this, because if you can attract people to spend periods of time in rural communities like that, the evidence is, particularly if they are in training positions or in their undergraduate education, they do come back, and that is definitely part of the recruitment attempts we're making. We're also looking at a number of other ways, for instance, the consultant jobs in the emergency department at Whitehaven, latest round of adverts, also providing them for a day to work on the Great North Air Ambulance, because that attracts a certain person and calibre that will come and work there, given that incentive. There are a number of other schemes. We had today, I chaired the first education board, which spans all of the healthcare trainers, including UCLAN, Cumbria University, the Northeast connections, where a lot of our traditional rotations came from. And so we're starting to gather together those providers. We're also starting to train not just doctors, but physician associates and assistants. So through a number of directions, we are attempting to gain some traction on the recruitment challenge in this area.
Sorry, go on.
I was just going to add to that, that it's also our nursing workforce that we need to be thinking about. And we are doing an awful lot of initiatives across Cumbria Partnership and also the Acute Trust. We're looking at some joint recruitment opportunities. We're also working very closely with our universities in order to grow our own staff so that we are able to support people through training to get qualified nursing positions. The other thing that we're doing is investing in training and development of our staff to make sure that they've got the appropriate skills. Certainly going forwards in the integrated care communities, we need to think about the different types of skills that people need to have. So we are really thinking about that. And in addition, we are doing some work with an organisation called English for Nurses, which is an international organisation who look at how we can support nurses to come from Germany and Italy and Spain to provide additional workforce for us. So we are doing an awful lot of work around our nursing workforce and also our therapists and allied health professionals. So we are doing lots of work around that.
Just a brief point, if I may. Is it Dr. Hill or Mr. Hill? Dr. Hill. And Dr. Hooper's point here, just connecting it back to that vision, that if you make the assumption, obviously at this stage it's an assumption because consultation needs to conclude, that we would be developing services around the community hospital and the integrated care communities locally, then think about the advantages of offering, which is what we're discussing with the universities, training programs for doctors and nurses, extending their responsibilities, in particular for nurses, in different settings as part of one team. So you spend some time in Keswick, some time in parts of the community, some time in the hospital. And at the moment, a lot of that's fragmented. So that's what, getting behind that vision, that's what it means, is sort of bigger teams. And it's a bit, Joanna was talking about the minor injuries service. One of the things that we're doing there is looking at the total workforce that we've got between us in people who are skilled in minor injuries and emergency care management, and thinking about them as a team and moving them around as resources in these settings. But I just would reinforce the point, we can't do that in every location, but we can do that in a selected number of consolidated locations alongside our hospitals.
I'm Susan Leeton. I'm part of one of the local churches. I'm on the Keswick Town Council, but also I work as a self-employed carer. Now, it seems to me some of the biggest issues we've got are the recruiting and the retaining of staff in hospitals. And I can see why the preferred options can be supported, by reasoned arguments. That I don't have an issue with that. It's the practicalities of the integrated care and the early supported discharge that concerns me. If we've got people in hospital who could be transferred to the community hospitals, then from the community hospitals into their own home settings, I'd like a bit more information about how this may be rolled out, the extra support given to the social care sector and the home care level. How sort of encouragement can be made for contracts to be better than 0-hour contracts, because a lot of pressure is going to be put on those people. I get people ringing me up saying, do I have any hours to spare? Because the agencies are struggling to cope, and there's a lot of people need care at home, and there aren't as many people to do it as is needed.
I'll have a go at that, because what you've done there is posed one of the most important questions that we have, really, in terms of health and care. So I would be the first one to admit that I believe that our reliance on carers is underestimated and in some sectors probably undervalued. From my perspective in health and care, what I've seen here in Cumbria and my experience of what I see here in Cumbria is a real willingness and a real desire on the part of the local authority to really strengthen that sector and to have more, not less. Now, that is a challenge in terms of the financial climate. Everybody in the room knows that that is a challenge. So certainly from a health perspective, we don't see any distinction in terms of providing care between a local authority boundary and a health boundary. So that is where we need to break down some of the fragmentation, do more, and actually provide more in the home setting. So that is our commitment, and certainly in terms of what we're consulting on in relation to integrated care communities, one of the most important factors in that is providing sufficient care in people's homes from whatever sector, but actually valuing what people give, actually seeing that as a core part of the care package, but strengthening that from a professional perspective too. So that is a real desire and a real commitment as part of the integrated care community development. So I know that doesn't answer the question fully, but certainly there's a real acknowledgement that what we have currently isn't enough.
I'd just like to hand this microphone over to a GP colleague in the audience. I was desperately trying to catch your eye to see if you could help us with this, just to give you a bit more value.
Thank you very much for answering that question. One of my huge frustrations with this consultation that it's almost all about hospitals. And hospitals, yes, they are important, clearly very important to everybody here. But the solution, or a large part of the solution to the problems in North Cumbria is not in the hospital, it's in the community. So one of our biggest problems at the moment is that there isn't sufficient care to get all the people out of hospital that we need to. So I absolutely agree with Joanna that our carers at the moment, particularly those working for private organisations, are undervalued and under-rewarded. I think they have no career structure, they have very little training. But if you look at some of the carers that are employed by the local authority or those employed by health, when we have vacancies in those, they're accused down the road with applications, quite opposite to what happens with the private, because they are treated differently. So yes, we really need to start regarding our carers in a different way.
Thank you. Can we move on? This gentleman next to...
Hi, my name is Adam Paxson. I'm a Keswick resident. I'm a member of Keswick Town Council. I'd like to introduce some thoughts about scale to the argument this evening, to the debate this evening, the consultation this evening. We have healthcare in big letters up there, but it's been made quite clear to us that this is all about money and efficiencies. We as people, as cultures, we tend to live in large urban areas because it's more efficient to provide services to where people are collected. We are so much the opposite of that. There are areas of poor health within our county, but local to this area where you sit now, our health is distinctly better than average. There can be benefits in being on a more human, smaller scale. We're a community. We know each other. We are already integrated in many senses. We can, of course, integrate ourselves more. But why are we already so integrated? Because we have to be. Because we understand this community here. We understand the geographical restraints. Recently, you may be aware, the A591 was washed out in a flood. We live in an area, you take out one road and travel by road becomes very much more compromised. So I would say that I feel heartened to see that of the 4 options, in Keswick's personal case, there is an increase in beds and a will to recognise what Keswick has started and to improve the integrated nature of Keswick. But I'm also mindful that the decision makers are likely to be distant from the county and that the economics that may be being applied may be on raw numbers, and things can be hidden in numbers. And why is our health better? It might be because we're smaller. That is an example of something which is going to be hidden in a statistic. And while option 4 is still on the table, the bigger picture in terms of savings of per capita spend is attractive to someone who's just looking to save money. And I'm interested that it was mentioned by yourself, Stephen, that there's no consideration for economy of scale in rural communities. So that leaves me a little nervous that exactly the things that we are doing well here could be undervalued. And if we go to option 4, then all our integration suffers. Because if we lose the beds, our number of GPs is challenged, all our voluntary services are challenged. So everything that we have, it becomes so much worse. So how can we engage with this consultation in light of that?
Well, I mean, I think I find it difficult to disagree with a lot of what you said there. I think they're very insightful comments. 2 or 3 things I would say. The thrust of the integrated care communities and what goes beneath that, which is you described, so I won't go back over that in detail, is about maximising localities. Now, localities can range from 20,000 to 500 people, and even within the integrated care communities, there will be a number of localities. And the concept of the integrated care communities is that the resources are directed, I hate this phrase, people use the phrase co-production, but let's just say together by the people in the area or the locality and the people who provide the services. And that's absolutely what we're trying to do. So I can't disagree with you. I think on your point about scale, there are different dimensions of scale. So, for example, I don't think any of us, if I could use an acute example to make my point, I don't think any of us would want to see a surgeon who's a gallbladder specialist who operates 5 times a year on a gallbladder. You'd want to see someone who does it 150 times a year. And one of the challenges we've got in relation to scale and quality is we cannot get to that level of national standard and expertise in some of our areas in the way that we're currently organised. So, you can't do everything in a local setting. But for me, there are sort of 3 levels. There's the level that you're talking about, extremely important, and it links to the point about caring as well, very much, I think, which is the locality level. Then I think there's a level which might, in Keswick, might be a locality in Keswick, actually. Then there's a sort of what I've been describing as a hub or a rather more substantial consolidation of services, let's say in this context around Keswick and its surround, where you draw in social care, acute services that make sense. And then there are those things that you really need to do just at one level for the whole community. Now, to my mind, that'll be a smaller number of things than in the other two dimensions. And I've tried to explain simply, that is our thinking, actually. So I think we're very much with what you're saying. Just one final point. You start off by saying it's all about the money. I mean, we have to, I've said it a few times, we have a finite resource. We have to do the best that we can with it. And obviously we're in a, frankly, it seems to me, for a number of years looking ahead, if you look at the Chancellor's statement, in a very different world to the one we've been in before. What I was trying to get across was, we do have a case to make along the lines that you're saying, and we're making it. I can't guarantee that we'll get anywhere with the Treasury, but we're trying to make that case.
My question relates a little to Adam. Sorry, my name's Anne Martin. I'm a Keswick resident. I was just ruminating on how we, as Keswick residents, have 2 levels of problem or opportunity. The first is to persuade you guys and the success regime to back option 1. And I think in many ways what we've heard before was suggesting that is the case, and that's at the parochial level. At the larger level, it seems a possibility. Ever since this all started, funding of the health service has got worse. The issues of cuts of funding and changes in the thinking are getting tighter and tighter. Somebody at the front asked what we should be doing to assist, and you talked about writing about our individual stories and whatever. I'm more interested in the distance that we are from Westminster, and indeed the rural versus the city centres, and whether there's another, well, 2 things really. Whether there's another action where we should be writing to the Secretary of State, to politicians, taking action of that sort. And secondly, the extent to which at this stage, because I can't believe you haven't had high-level discussions about the success regime and how it's being seen in its current options with Westminster, what's being said at that level?
Yeah, so I just on your general point, I mean, again, I think we'd find it hard to disagree. It could only be helpful if people offer that view, because that's the view that we're offering. To offer you an insight into the national discussions, Sir Neil Mackay, who's not here, of course, as you know, chairs the success regime. He and I have been in a number, and he more than me actually, of meetings with ministers about this whole process. But I can assure you, we have consistently made that message really clear, and we're going to continue to do. I mean, to some extent, it's not really about the consultation. It's much more about, I think, the point that your colleague down here was saying about, is this the right way? Now, one of the issues that ministers would say is, well, you're not the only area with this problem. And I think that's true. Parts of the Southwest would probably experience similar dynamics. So what we're trying to do is create a momentum that addresses that issue. And I can assure you we're really, really working hard on that. But we're working hard in a more difficult time to solve it, because, as you both have pointed out in that conversation, it's a lot tougher ahead than it has been up to this point. But you can be assured that's what we're doing. And the short answer to your question is we haven't got a yes, and nor have we got a no at the moment.
My name's Claire Spedding, and my question is about transport. We have every reason to be very grateful for the support that the paramedics and the ambulance service have given and in the past. And we're very conscious of the area where we live, with narrow roads and remote locations which have to be served by the ambulance and paramedic service. In your consultation document, you refer, in connection with children's and maternity and stroke provision, for extra training which will be given to our excellent paramedic service. Is there something you could tell us more about this, please?
Yeah, that is one of the options we're looking at. We've been working closely with our other partners as part of the success regime, and one of the options, if there's a midwifery-led unit out west in West Cumberland, there is one of the options to provide a dedicated ambulance vehicle in the same way they do down in Pembrokeshire. And one of my colleagues went down to Pembrokeshire to see how that works. And one of the options there, again, that we're looking at, one of the possibilities, is to increase some of the skills of the paramedics so that we have critical care paramedics to assist with those transfers if that is one of the options we go for. So it would be, there are various things that can be done. There are different programs for critical care paramedics, and that's one of the things we're looking at.
Moving on. Any more down this side, folks? Come over to this side, please. The lady in the glasses at the back, just give us your hand again. Thank you.
Good evening. I'm Sally Bickerdike, and I'm reading this because I would like to say what I'd like to say this evening, because I've not long been out of Keswick Hospital. I'm a former clerk of Borrowdale Parish Council and also St John's Castle, Righam, Wythburn, and I know that the people in there have really supported the hospital and found it so important over the years. Medics can fix problems for people, but I believe everyone should have a chance by giving access to the specialist hospitals. There are so many rural areas in Cumbria, miles of travel either for patient or visitor to these main hospitals, but the recovery should be close to home as possible. Keswick has had 3 major floods in the last 10 years. Access to the hospital has been so important during these days. Thousands of visitors come now all the year round, not just walkers, but for the extreme sports. And Keswick Hospital has been the first point of contact. I have always experienced good health, but recently have been very ill, suffered a brain bleed near Littletown Farm, Newlands. Luckily, I was quickly taken by taxi to Keswick Hospital, and Newlands being one of our remote valleys. They passed me on to Newcastle, where I spent 9 weeks. I cannot remember anything, but they did an excellent job putting me back together, and I will be eternally grateful. A friend asked if I could be admitted to Keswick to fully recover. Friends could come and see me there, and my family, who live in Hong Kong and the south of England, could stay in my house. They would be close by. I began to regain all my health. Everything began to work, and I could remember people I knew, the food and the staff. Friends tell me that I really didn't start recovery until I got to Keswick. I believe food is very important in recovery, and we are so fortunate in having fresh food cooked in our hospital. The staff are amazing, doing so much for me when I arrived, but gradually left me to do things by myself. 3 weeks later, I could go home, supported by the local outreach team. Keswick did so much to help me recover,
and look after myself once again.
A wonderful story, and you're looking the pitch of health, I must say. Okay, we're going to move on, folks. Any more questions? Oh, so can we go to the man in the blue, and then we come to you in the front? Yeah, thank you.
Roy McNamara, you understandably have concentrated in the integrated care in the community on the health side. But as the last speaker demonstrates, it is the social care as well that makes it possible for that care to be delivered locally. There have been some passing references to social care and the local authority, but I don't hear from you any new steps to integrate the two. Is the county council on board with what you're saying? And if they could be, would they be, financially, if they could be, would they support all that you're doing, and would they put in the equivalent sort of resource to these ICCs?
If I start, I think Joanna will probably comment as well, but I think it's important to say we're working very closely in partnership with the local authority. And what that means is there already are shared resources between us. Again, a bit of NHS jargon, something called the Better Care Fund. So some of the things that we refer to, we basically, between health and social care, put a pot of money together to do exactly what you're describing. However, you're absolutely right, it's not enough. And coming back to what you were saying over there, one of the challenges, as I understand it, I think other colleagues might be more knowledgeable than I am in terms of the detail, is that there's a general set of issues here, as in the rest of the UK, variably, around the traditional pattern of the care sector. In some places it's collapsing, frankly. And therefore, where the local authority and ourselves together, you know, with the public and the people who use the services need to move, is to create new ways of delivering care. And what that means in practice, for me at least, is when these integrated care communities are established, what you're really talking about, in my experience from other parts of the country, are doctors and nurses, social workers, community practitioners, third sector or people like Age UK, carers, all part of the same team, working under single directed leadership in a community. Now, I'm fairly clear that's what we're proposing in terms of implementing these changes. I think the second thing in the context of this is the resource question. It is a bit frustrating when we talk about the pressure on beds and so on, that there often are beds in the care sector. They're just not the right type, and there's all sorts of issues to do with that, to do with some of the things that we were talking about when we were talking about the care sector and private employment, some of the recruitment issues. So one of our strategic agendas, really linked to where we decide the hub should go, is how do we jointly deploy our capital resources and our other resources to do just the sort of things that people have been describing. So in a nutshell, there's very firm, close working. Of course, the county council and the local authorities are taking their own view about this consultation, so it's only fair to them that they want to take a view on what they think is the best scenario, and therefore I don't think you should take for what I'm saying that everything that's being proposed is being supported. We'll hear about that as the consultation progresses. But that is the direction of travel that we're all signed up to.
Yeah, just to add to that, firstly to apologise, I've obviously not been clear enough, but specifically in relation to the concept of integrated care communities, I'm working really actively with the local authority and with social care in particular. So the Director of Social Care is relatively new to the county, a lady called Brenda Smith, And in fact, she has vast experience of developing integrated teams and actually running integrated teams in communities such as this. So we're working really closely together. Dr. McGreevy too is working really closely with the local authority. The concept is one team, one place, and that would certainly, we would hope that that would include the local authority, and we're working really actively on that now.
I think if the local authority and social care in particular are not involved in integrated communities, then they won't work. I think the integrated care communities need some investment. So my ambition in life, because I'm deeply involved in developing ICCs, is to take some money out of Stephen's budget and get it out into the community. And I hope he's not surprised to hear that.
My name is Gillian Thorne. I've lived in Keswick for only 27 years, which most of you will say doesn't count for anything. I am worried about the financial aspects of everything that has been suggested this evening. I'm very pleased. It sounds as if great things have happened in the future, and particularly at Keswick, centred around this hospital. But my observation is that everything for many years and in the future, there is never enough money for it. And in the powers that be can easily at any time decide on some specific thing that we are planning and is going to happen and just axe it just like that. Now, it seems to me very important that the people who are fighting on the other side should realise that axing one particular service supplied by an integrated hospital, that money supposedly saved from that is not going to immediately transfer to deal with the problems, which are many, of Whitehaven or in Carlisle, because little, if any, of that money will provide better services there, because if you axe things in Keswick, axe the minor injuries unit, more people go to A&E in Carlisle. It just transfers a lot of the work and a lot of what was being done here, and that doesn't seem to be considered. Thank you.
And I think you've made a point. I think a lot of the financial questions have been covered. If there's anything else you want to add earlier to what you said, we are going to move on to the next question. Anybody who's not asked a question, can we just go to the bottom of the room, please? There's a couple of gentlemen there in blue on the same row, and then there's a chap 2 rows behind him.
Hello, I'm Dr. Tom Donaldson, and I was a GP in Keswick for 36 years, lived in Keswick for 62 years, so I think I know what's going on. First thing is that Keswick has genuine problems with medical care. We're very much cut off from all sides, from the West Coast, from Carlisle, from Eden Valley. We have a lot of elderly people, and we've got a lot of visitors. Our population is probably about 3 times what you think it is, and the visitors always fall off the hills and have to be carted into the hospital to be repaired. So we absolutely need to have a really good all-round hospital in Keswick. Now, the other thing is that a previous group and yourselves are talking about treatment in the township. Well, that's wonderful, but I just want to know how it will be done. I mean, the council nursing home is closed, so that's off. You say the local GPs, well, they say they have too much work already, and half of them are trying to retire. You say the social services would scoop in and look after people at home. Anytime I spoke to them, they said that they were terribly short of money and couldn't cope as they were, apart from enlarging their work. and they cannot get any local workers. The local workers want to work in the hotels, so they have to import people from Workington who, if they work for 4 hours, are only here for 2 hours. So I'd like to know how that will all work. And as far as the hospital is concerned, if the government says there's no money for Keswick Hospital, then you've got to tell them to find the money for Keswick Hospital.
Actually, Doctor, I think you've just told them much better than I could or anybody else. And it has been recorded, so I'm sure they'll get that very forthright message. Just a couple of points to make about what you have said there. Go back to what you were saying, I think, first of all, about medical care, and it does come back to something I've said a few times this evening, that one of the issues that we've got, and I think this faces all health and social care communities, we can't do everything everywhere. So, and especially now that we have the resource, the money outlook that we've got going ahead. So the difficult decisions here are to do with what we do where and where we focus our effort to invest. So I think there's been a constant theme this evening that it's fairly clear to me, I mean, it's the first time I've met with you all, that you're all for Keswick being one of those areas of consolidation, which actually is the proposal. So that seems to me we're on the same page. The other thing I think it's important to note is, and this is partly about technology and the advancement of technology, which again, medical colleagues in the room will understand much better than I can. But, I mean, this is moving so rapidly. New drug, new treatment, new procedure, virtually every other week. We must remember that what we're talking about here is not just about the hospital. I know the hospital is important, but I think we're actually talking about what you can do in people's homes. And if I were to get in a time machine and move 5 years ahead from here, you know, I think there'll be lots of things going on in people's homes around healthcare that's not happening now. Things they can do for themselves, things they can do with support from their carers or from specialist nurses. You know, chemotherapy is being offered today in parts of this country in people's homes. They don't go anywhere. They don't go to their local hospital. They don't go to a district general hospital. It's brought to them in their home. And we're going to, I mean, that would have been unthinkable 10 to 12 years ago. So I think we also need to appreciate, I understand all the passion, that a lot of this thinking is about what can we do around the home as well. And I think that would deal with some of the concerns that you raise. Finally, unfortunately, we have to work with the money that we've got. So we will convey your message, and let's see whether that makes any difference to those that allocate the resources.
Hello there. Yeah. Charles Hope, Vicar at Keswick St John's. Excuse my ignorance for asking this question, but I see that the consultation document has 5 logos on the front of it, and it also includes references to 2 other NHS trusts, Northumberland and Newcastle. That's 7 different organisations, which is great. On page 13, you make reference to mental health. I don't know how things work in this part of the country, whether the mental health is a separate care trust or is part of one of yours, but I'd love to have some more information as to how mental health, I know you're issuing another document on inpatient mental health, but what about outpatient mental health, including within that crisis care in the community, youth and adolescent mental health care, and addictions health care? Because all of those tend to be things that get swept under carpets because none of us have psychological problems, none of us have addiction problems. Well, we do actually if we dig beneath the doors and look behind the doors and the skeletons and all the rest of it, but they do need attention, and I'd love to hear a little bit more about those things, please.
Yes, so Cumbria Partnership Trust actually provides mental health care in the large majority across all of Cumbria. It's not specifically something that we're consulting on here, but certainly in terms of the underpinning principles of providing good mental health for people, actually a lot of that should be done in these primary care communities, the integrated care communities. So mental health is a central part of that. So the services that we currently operate, we would look to actually wrap around communities. That's not fully worked through yet in terms of the implications of that, but actually the concept is that all of the services that we operate would form part of those integrated care communities. Now, I could talk to you all night about mental health care, but I am conscious that it doesn't form part of this consultation. But I'd be more than happy to come back and speak to the community about what services we are providing, what developments we've got in place across the county, and specifically some of the really exciting opportunities that we've got to provide better crisis care in the north, the east and the west of the county. So I'd be more than happy to come back and speak to the community ad infinitum about mental health care if that would be something that you would like to hear.
Thank you. We're just going to go to this gentleman at the back. He's just been waiting. Will you, sir, in the blue? Yeah. And then I'll come to you.
Good evening. My name is David Lowe. I'm retired and happy to be retired. My story is not one of great faith in the National Health or its subsidiaries, as I've been let down badly over my last few years when I've needed their help. I retired from the taxi business about 6 months ago through ill health. My back was damaged, and I went to have a scan at Penrith and was told that it would be doctored at Preston and I'd have an injection in my vertebrae, which was fine. I phoned up both concerns, the scan people and the hospital, to check up that the scan would be sent to the hospital, and they both said, don't worry, it'll go, you don't have to do anything. The letter that I'd got had said, you must take it with you, the scan, but I phoned up just to check up. When I got to the hospital in Preston, which is quite a long way away, and I had cut a holiday short to get there, booked a hotel to make sure I got there on time. I went in, and they said they'd not got my scan, so they couldn't do anything. I had to rebook and check again that they got my scan next time they had. Fine, I'm not worried about myself in this way, but it seems to me that things have broken down all over the shop through wastage. Computers, people relying on computers and not doing their job properly behind them. This was my problem there. And another problem I had was when I was taxiing, I brought somebody up from Lodore Hotel to Keswick Hospital fairly late one night and knocked on the door and said, can I help this person who's injured? And they said, no, you'll have to take them to Penrith. Now, if that person had been dying, well, I'd perhaps put my case more strongly, but I felt disgusted that we'd let down this visitor to our town in that I thought the hospital was open and hadn't been told that it was closed after 6 o'clock at night. It was general cutback, and I don't feel that the people who are in charge care as much as the people who are actually working. This is my experience, but make of it what you will.
Okay, well, thank you for sharing that. And I think, to any member of the public who has a poor experience, we would all support, you in reporting that and taking that and escalating it, because people ought to have a good experience. I don't think it's particularly anything we can cover tonight, so if you don't mind, I'm going to move on. Thank you. Can I come to this gentleman in the green? And there's a lady in the back. And I'm conscious of time, folks, so if you do have a question that's not being covered earlier, please put your hand up. If it has been covered, we're going to move on.
Good evening, Mike Lover, a resident of Keswick. Just on the question of numbers, I'm sure that you have factored in, and you need to check this, because my understanding is that although we have a population of 5,000 approximately in Keswick, we have 5 million visitors. So if you're looking to build a case for numbers, just check out that figure. I'm pretty sure that's a correct figure. If you want to feed some numbers into the government, 5 million visitors is not insubstantial.
My name's Isabel Hogarth. I'm a resident of Keswick. I was pleased to hear that the oncology service is going to be improved at Carlisle, but I'd very much like to know which comes first, because you're going to need consultants. At the moment, the consultant I see comes from Newcastle, which seems an awful waste of money, but at least he comes. I want to know what is going to be done about the premises, because I can't see any consultant worth their salt wanting to go to that unit. You can't find it. You go down behind bushes, down behind a little pathway. You go through doors that are chipped and the paint looks dreadful. As a patient, it doesn't give you much confidence. And I can see that no doctor or consultant is going to want to come and work in that sort of situation.
Yeah, no, I can answer that question directly. Just to make the point, I didn't say so now because I was talking about the investment, but the service. So the investment's about replacing the equipment, which really is, getting to a point where it's not in a good state to carry on providing a local service. So we want to invest a large amount of money in up-to-date, state-of-the-art kit. But we're doing that in conjunction, in partnership with Newcastle Hospitals. Newcastle Hospitals will run that service, but they'll run it locally here in West, North and East Cumbria. And as you rightly say, really as it stands, the way we're organised, we will not attract people, but we will attract people to be part of a team linked to the specialist hospital. That is a really big part of what we're proposing. So I was just talking about the capital investment. There will also be investment to support more doctors and nurses in cancer as part of that package. On your point about the building, absolutely, we're knocking it down and replacing it.
We missed the lady in the purple here, so can we come up a couple of rows, please? I've never forgotten you, say.
I'm Gail Stevenson. I've been a volunteer at Keswick Hospital for 18 years, and I thoroughly enjoyed it. And I've watched over the years the staff and the care, the compassion, and the dignity shown to the patients themselves, to the volunteers, to their visitors, to their family, is second to none. I've worked in quite a few hospitals, even a famous teaching one in London, and Keswick is high up there in the list. It's the cleanest hospital I've seen. The cooks will make you a meal, whatever the patients want, they will give it to you. You don't get that anywhere else. The hospital is a family at Keswick. Keswick itself is a town full of families. We support one another. Keswick needs the hospital, and from a humanitarian point of view, we need it. If you shut the hospital, you destroy part of Keswick. So please think on that when you make a decision. Thank you.
Thank you. Have we got any more questions, folks? We've got a few more minutes. I'll come to you, just make sure everybody has a chance first, okay? Any more, folks, before we finish up on this very last question? Oh, this lady in the red, and then we'll come to you, and then everyone will have had an opportunity.
Mary McNamara, I have two questions. One is, can you say anything yet about how you envisage the voluntary sector fitting into your integrated care plan? And secondly, in your winding up, could you give us a summary of where we go next and the timescale and who will finally make the decision? Thank you.
Yeah, it's fair to say that we haven't thought as much as we should really about what the voluntary sector actually contributes in terms of care communities, but it's absolutely central to our thinking. I think it was Tim who reflected things are moving more slowly than we would want them to. I think that's really fair to say. What we would hope is that through this consultation, we could start to accelerate some of that and involve a broader community, a broader church of people in each of the integrated care community areas. And fundamentally, that would involve the voluntary sector. They're absolutely critical to the success of making a care community work. And certainly in terms of everything that we see across the community, they play a vital part, but we haven't paid it enough attention yet. And in Keswick, things have moved more slowly, and we really need to start to accelerate that now.
And so for our final question, if we go to this lady in the front, please. And then we'll do some summing up at the very end then to cover those.
Lucy Besley, I've lived here since about 1970. One of the you're talking about trouble with recruiting people. The main trouble is that we are blighted with second homes, and most people, the housing is so expensive that the people, nurses and people like that, simply cannot afford to live around here. Have you given any thought to that? Do you put any extra money in for your people?
I think it's very hard for us to influence the sort of social dimensions there that we can't really influence. I think what we are doing, I think both of the trusts are doing, certainly, for some groups of staff, we do provide accommodation. And more particularly, we have a plan that we share about bringing people into the area. So, for example, if you were coming here perhaps as a consultant and you have a wife, perhaps, who is also another professional. We're looking to make sure we can give both people jobs to get the families here. In some cases, we're paying larger premiums because it's cheaper than paying agency staff. In some cases, we will help people to buy a property locally. So that we're doing, and that's a few examples, there's about 20 things to pick from the list. I don't think we can do anything about the sort of social mobility and how people spend their money on second homes. I think it's probably an issue for Keswick and lots of other attractive places in the country. It's a good point.
Okay, so we're going to come to a close. There's a couple of things, really. One thing that everybody clearly wants to know is what are the next steps? What are the timescales and what's the decision-making process? So I'm going to ask for you to finish that off. But one of the things that I'd like to ask for you to do this evening is clearly a passion for your local hospital. Have your local say. This document that you've got as a consultation document, it's got the questionnaire in the back of it. That's your opportunity to register your view. So whilst this evening's being recorded, if I was the analysis person looking at this report, I can't count this evening. It's a quality, but that's the fact. And please fill that in because you want your voice to make a difference. I'm going to hand over to you to give us some summing up, please, and then we're going to close the evening. Thank you.
Okay, so before I just clarify exactly what the next steps are for everyone. Can I just, on behalf of the panel here, thank everyone for coming out tonight? And I'd echo what the chair has said. I think it's quite clear to me, and sure my colleagues here, the passion, and actually it's more than that, the sort of deep support there is for your local community and its hospital. So no doubt that will resonate with us and indeed in the feedback into the consultation. So thank you very much for taking the time to do that. and we've listened to you very carefully. So what happens next is the consultation formally closes on the 19th. So again, to emphasise what the Chair was saying, you've got between now and then individually to respond as much as you can and encourage others to respond to the consultation in the way that you've just described. It closes on the 19th. There'll then be a period of reflection and consideration about all the responses, about everything that the consultation is about. And that will take us probably into February of next year, because part of that, alongside the reflections that we might make, we have an independent organisation that's also looking at all the feedback and trying to give an objective perspective on that for us as well. And we're going to get that back towards the end of January, as I understand it currently. So there's going to be a bit of time to think through, and it might well be that within that there may be one or two other discussions, or not formal consultation meetings, but discussions in some shape or form with the community. The responsible organisation statutorily for taking the decision is the Clinical Commissioning Group, the Cumbria Clinical Commissioning Group. And the date hasn't been established, but as I was saying at the beginning, around about the early spring, I'm sure once we get past Christmas, we'll start to be able to say what that timetable is. The Clinical Commissioning Group will make a decision, and that decision will be informed by the acute trust that I represent, the partnership trust that Joanna and Claire represent, and certainly a lot of input from primary care colleagues in the various GP practices and communities across the area. And that decision is taken by the health service. Now, what happens after that is, if everybody agrees with the outcomes that are proposed, and the most important thing to say is, one of the bodies that formally needs to agree is the Overview and Scrutiny Committee of the County Council, because they have the opportunity to comment, and critically, if they don't agree, the opportunity to refer any decision that they don't agree with to the Secretary of State. So one route is everybody agrees and then we move forward to implementation. Another route might be when the Scrutiny Committee considers the outcomes of consultation in the same way that we do, and the decisions that are being made, if they decided to refer it to the Secretary of State, then it's his decision. Okay, hopefully that's clear, but those are the next steps.
They are. And I'd like to take this opportunity, if you wouldn't mind, ladies and gentlemen, to thank the panel for coming. I think they were very candid. I think they took some tough questions. You're not an easy crew. You've got good questions, which is brilliant. I've really enjoyed being here this evening. I hope you have a safe journey home. I hope it's not snowing when I'm driving home, but thank you very much for your time, and good night and God bless.